Okay, Polly, do you want to kick off?
Yeah, good afternoon, everybody. I can see there's still a couple of people joining. We've got participation numbers kind of whizzing in. So I'm just going to hold off another couple of seconds before we get going, but we're really excited that you could all join us this afternoon. Okay. Well, I will get started because some more people might be joining us, but we've only got an hour and a half today, so keen to kind of get going. My name's Polly, and I'm very delighted to be hosting this TEDdy Talk this afternoon. It's great to have such a large turnout. I know we were expecting quite a few people, so I'm really pleased that we've got all of you along for the first TEDdy Talk of 2025. Today, I'm absolutely delighted that we have Ian Smith with us. Ian is going to provide us with insights both into the NHS and also into national defence. Both feel very timely, particularly, dare I say it, after certain comments made last week. Ian has a wealth of experience in both these areas. He's currently chair of the NHS Heartlands Trust in Surrey, having previously served as the chair of King's College Hospital and the CEO of the General Healthcare Group. He's a non-executive director of Strategic Command at the Ministry of Defence and has worked as part of the diplomatic team with the Quartet in Israeli-Palestine peace process from 2010 to 2013. So we couldn't be more delighted to have you along and have such a level of high expertise. Ian will talk to you a little bit about the format, and I'm going to keep an eye on the Q&A. So if anybody does have any questions and answers as we go along, please do put them into the chat. Thanks very much. I'll hand over to you, Ian.
Thanks, Polly. So what I plan to do is start with the NHS. So what I'll plan to do is about 25 minutes on the presentation, then open it up for discussion. I'm really keen to hear your views and opinions and questions. And then if we use that full time, I'll do about 10 minutes on defence, and again, open it up for 20 minutes of discussion. I'm quite happy to make this interactive, so if you've got questions during the time I'm speaking, then please put your hands up and Polly will interrupt me, and I'm very happy to stop and let's have a discussion. So next slide, please, Emily. So summarizing where I think we are with the NHS. You know, it is an irony that we have world-class science. We've got 3 of the best universities in the world in the top 10 in biomedical science. We've got great, well-qualified, committed clinicians and carers, and we have a system that is national and free at the point of need. However, we have some of the worst outcomes in the developed world in both health and social care. So something clearly is not working, and I'll give you my view of why that is the case. Basically, I think we've got a fragmented, dysfunctional system with a command and control mentality that makes delivery on the interface with the patient very difficult. And I'll talk a bit about what I believe the answer is to that, which is devolution of management authority to integrated care systems who can manage patient flow and outcomes efficiently. Next slide, please, Emily. So very quickly, I could have chosen any metric, cancer survival rates, whatever you like. But the UK, I've chose this one. The UK has one of the highest avoidable mortality rates in the developed world. The United States is worse than us. It's worth noting that the United States is bimodal. So it has about, it has a very poor element of its population, probably about 20–30% of its population who struggle to get healthcare, to afford healthcare. And so their outcomes at that end of the inequality spectrum is very poor. Yet it also has obviously some of the most elite advanced healthcare in the world at the other end. So the average is very poor, but that is very bimodal. Next slide, please. The NHS was perfectly designed when it was created in 1948. In 1948, people lived on average to the age of about 60, and they would die within 6 months of their terminal illness. It made sense to have a distributed, often single-handed GP surgeries for minor ailments, but mostly to dispense antibiotics. Antibiotics were discovered by Fleming at St Mary's in London in 1928. Isolated and purified by Florey at Oxford University in the early 40s, and during the Second World War, it was mass-produced mostly by the Americans. So by the end of the Second World War, antibiotics were the wonder miracle drug, and in many ways still are. And GPs then and now, are the people who dispense those. Social care was separated back in 1948, and it didn't really matter at the time because people weren't aging. The attitude to mental health was very different in those days, which we find quite shocking now. We would lock people up into mental health asylums, often for the duration of their life, which we don't do anymore. So we had getting on for 200, 300,000 people locked up in mental health institutes until as late as the 1960s. These days we have 15,000 secure psychiatric beds, and I think we'd all agree those people should be in the community. The problem is that often the community services are not adequate enough to look after those people. The system was set up very deliberately as a Soviet-style system. That sounds very strange in today's world, but at the end of the Second World War, the view was that the Soviet central controlled economy was the way to run an economy. The Soviets had effectively won the Second World War. And so the NHS was quite deliberately set up on a Soviet command and control centralized system. What has happened since then is that the epidemiology of disease, the demographics have changed dramatically since 1948. Average life expectancy for somebody born today is 85, not 60. And those people will live probably 10 years in relative ill health because of aging and also because of lifestyle choices. We have in the UK some of the highest rates of obesity, diabetes, alcohol consumption, and illegal drug use. And that's, a number of those, all of those factors are driving the poor health outcomes that we have. And that's been exacerbated by poverty, which has increased over the last 15 years or so. And we really have got quite shocking inequalities between the least deprived and most deprived in our society. To take one example, neonatal and infant mortality rates are about 3 times higher for the most deprived in our community compared to the least deprived. And actually, those rates have shockingly been increasing for the most deprived over the last 4 or 5 years. Next slide, please. And we have a chaotic system. Whilst we have great clinicians and carers, they're often wrestling with the system to deliver the care that they want to their patients and residents. And that's because of constant reorganizations, institutional jealousies. The biggest one is between local government social care and free at the point of care healthcare in the NHS, but it's also between primary and secondary care, between community care and GPs. So we have a highly fragmented system, and I've shown there a chart with a typical healthcare economy of about 2 million people, and you can see just how cluttered and how difficult it is to coordinate across that, and how disorientating and often hazardous the patient journey is through that system. We've underinvested very badly. It was a great idea back in 1948 to have a tax-funded system, but that has now got huge challenges as we went through austerity and people don't want to raise their taxes. So we've underinvested badly in IT and estates, in connectivity, and that has really reached crisis proportions at the moment. Also, the way that capital is spent is very poor in the NHS. Too often it's taken from the capital budget to shore up the in-year deficit. So moving CapEx to RevEx, and therefore leaving an estate. But also diagnostic facilities. We have far fewer MRI, CT scanners compared to nearly every other advanced nation, and we're over-regulated. So every time something goes wrong, we put in another regulation, another set of policies, don't take out the previous ones. So clinicians and carers are really operating in a system that's highly regulated and quite difficult for them to maneuver through. Next slide, please. And that's created a crisis. So just overwhelming demand in a highly fragmented system. And that has put huge pressure on the major sort of blockages within the NHS, A&E attendances, GP surgeries, and the ambulance service. I mean, you couldn't design a more fragmented, pressurized system than the NHS, and really no guiding mind. Nobody really looking at this as a system and saying, you know, how should this operate and how can we manage this in the best interest of patients? Next slide, please. The answer is integrated care systems. It is to take the natural unit of about 2 million people and to manage that system, manage the flow of patients through that system in the most efficient way possible, spotting bottlenecks, fixing the causes of demand, especially social care, and especially our lifestyle, our unhealthy population, because that is the only way that we're going to take the pressure off the ambulance service, A&E departments, and GP surgeries. So integrated care systems, which really should have been introduced, 30 or 40 years ago, finally got introduced formally last year. 42 integrated care systems throughout the country. And although it's early days, I think this is the answer to that problem. Next slide, please. Because within that system, you can really begin to manage the bottlenecks. You can manage patient flow. So in Surrey, we have what we call the critical five. And very quickly, what the critical five is, the first is keeping people well out of hospital. I'll come back to that in terms of well-being, lifestyle, community activity. But if they do deteriorate, finding urgent care pathways that do not end up with an ambulance and do not end up at A&E. For our ambulance service in the southeast, there's only 15% of the cases that the ambulances go to is a real emergency situation. The other 85% are people who've fallen minor falls or mental health crisis, which we could deal much more appropriately with a different resource rather than sending a very expensive, highly qualified paramedic team in an expensive ambulance. And 50% of those attendances by ambulance end up at A&E. So we've really got to try to keep people out of but if they do deteriorate, then find urgent care pathways that are more appropriate than ending up in hospital. Secondly, safe and effective discharge. Social care has been a real problem and disaster over the last 15 years. And it is a core part of why the NHS is under such great stress. Nearly 3 million people in the UK are not receiving an element of social care that they need. Those people do not get better, clearly. And as they deteriorate, they do call the ambulance, they go to their GP surgery, and they go to A&E, and that contributes badly to the problem. So fixing social care is a major priority. High-risk care management, typically 1 to 2% of our population are the most vulnerable, who require a lot of care. Probably 70% of those are frail elderly, often living with dementia. Another 20% would be acute mental health, and the balance chronic disease, cancer, COPD, heart conditions. So we've got to try to reshape a system that really looks after those 1 to 2% of the population who currently are the people who bounce around that system unmanaged, disoriented, and deteriorating as their pathway is unplanned and often pretty hazardous. Clearly, the fourth of the critical five, in hospital management, is crucial. We have a lot of benchmarks of best practice in terms of theatre utilisation, a number of procedures that should be done on a list by a surgeon called GERFT, getting it right first time, and model hospital. So we need to really manage an efficient hospital in terms of its outcomes and its productivity and efficiency, but also the flow of patients through the hospital so that we can move the patient back into the community, into their home or a care home as quickly as possible. And then the final one of the critical five is managing efficiency across the whole of that 2 million population. So if, as in Surrey, we have capacity for ophthalmology services in one hospital, yet we've got a long waiting list in another, then we should be able to take those patients from one area and care for them in another. But given the way that the system, the fragmented system currently works, it's very difficult to actually manage to get the information and data and also get the discipline of clinicians and managers to do the right thing by the patient. Next slide, please. And the key to this is moving back to community care. We're not going to solve the problem of the NHS unless we recognise that people's health and well-being is maintained, so the first of the critical five, in the communities in which they live, and that if they do deteriorate, that we find solutions within those communities, whether it's urgent care centres, minor falls units, or whatever. We've done a great piece of work in Surrey, identifying the 29 communities, towns and villages that people associate with. So these are not political boundaries. These are the places that people say they are their communities. They're typically about 50,000 people. And our task, I think, as public services, both the NHS, local authorities, but also the voluntary organisations, is to mobilise community activity so that people are looking after each other. There's a lot more self-care, and that we then reshape public services, social care and healthcare, around those communities of 50,000 people and embed those public services in a community that is vivacious, animated, and is looking after itself and after each other. So I think this is a really key part of what we're doing. Next slide, please. The key piece of work that really opened up this idea of neighbourhood teams, which is the integrated body within each of those 50,000 populations, within each of those towns and villages, was a bloke called Michael Marmot, who wrote a very influential and consequential report in 2010, which identified that, when you're born, 80% of your health and well-being outcomes will be determined by the wider determinants of health. That is not the NHS or social care, but your level of education, your lifestyle choices, your employment opportunities, your housing circumstances, and only 20% is sort of the emergency services of health and social care. And that was a really seminal piece of work and has really guided this move towards focusing on communities, reshaping public services around animating those communities and driving national and local policies that determine or concentrate on these wider determinants of health, education, lifestyle, housing, employment, and so on. Next slide, please. And then the task of the integrated care system for these communities of 2 million people is firstly as I say, animating these communities. But the second part is managing patients through that system if they do require emergency care or secondary care, and also making the operating models that we use standardized and efficient. It is rather shocking to me that every A&E department I go to has a different way of operating, from the one, 5 miles or 20 miles down the road. And one of the problems is that the NHS is so tied up in managing the emergency pathway, so tied up in day-to-day scrambling to look after patients, that it never really pulls back and says, well, what is driving this? What is the analysis? Let's put in standard operating procedures. Let's identify best practice and put that in evidence-based across the system. And that's what the integrated care systems should be doing. There is a problem. I'm going to finish in a minute, so please have your questions, comments, challenges ready. One of the problems, I think, is that the government is still a bit uncertain about how authority and management control should operate. So should it be the integrated care systems, who then should manage the hospitals, which are the biggest part of our expenditure, 50–60% of our cost is in the hospitals? Or should they do that from the centre? I think I believe very strongly, and I hope I've convinced you, that this has to be done within a system, because we are close to the population. We're close to what's happening in the hospitals, but also what's happening at their front door in terms of who's arriving at A&E. And if we can fix social care, then we have the possibility of solving the backdoor problem, that is getting people out of hospital safely and safely placed in a community setting, either their own home or in a care home. So I'm going to stop there and invite your comments and questions. And if you don't have any, I'm sure Polly and Emily will prime the pump.
Thanks, Ian. So anybody who has got a question, please just either pop it in the chat would be great, and then I can read it out, or raise your hand otherwise. I suppose one thing for me that I was just thinking about, Ian, when you were talking about it, about that, and Michael Marmot's kind of model and thinking about that kind of community idea, is I feel that's a very clear shift that's happened in kind of my sphere, which is more like the child protection kind of social work area, where we've kind of had this real move to this idea of contextual safeguarding. So you can't just look at particularly when we were looking at kind of teenage population and risks around teenagers and some of the issues that are coming up, you can't just look at their individual family environment. You have to be looking at the wider community and the supports that are in place, and really relying on things like you were saying, like the voluntary sector. So I suppose I've really noticed that shift in my field as well.
Well, that's right. And the way the system was designed in the past, it was people turn up in crisis, and we stabilize the crisis, and then we send them out again, without any follow-on care. And that's clearly not a good way of doing it for the patient, clearly, but nor for the system, because those people will deteriorate and come back. So we are trying to be much more person-centered in terms of that high-risk care management. Who are the people in real distress? Let's have a care navigator, probably a community nurse, who is curating their pathway through the whole cycle of their care to palliative care in the case of frail elderly, rather than just treating them and then putting them back into the mix, and then they arrive again at A&E or at the GP surgery. I think the other thing with children, and we have got a crisis in mental health, adolescent mental health, which has tripled, quadrupled in some cases. And these are serious conditions. This is eating disorders, self-harm. These are life-threatening conditions. And what we're trying to do, or what we are doing in Surrey, is to identify the school as the key nexus. So in the past, you'd have different agencies going into the schools, the education people, us in the health service, the social workers. What we're trying to do is join all that up. So we work with the teachers and the teaching assistants, because they really know their children, to identify early on those children who are having difficulties, institute a needs-based rather than a diagnosis-based pathway, because there's a rush to get diagnosis for autism and ADHD, which is often not that helpful, and the medication is often not that helpful. But get in early with the teachers who also know the family circumstances and the community circumstances. That is a fundamental change in the way that we need to go about healthcare.
Okay. I've got a couple of questions coming up, Ian. So first one, I've got one from David, who asks, what impact is the new government having, in particular Wes Streeting?
I think it's, to be fair to them, and I'm very sympathetic to the Labour Party, it's a tough rap, this, because it is a system, as I've described, that is in some difficulties. I would like them to be more assertive about social care. I think the Casey review, which is going to report on social care in 3 years' time, is going to be too long. I think it needs to, because we need to look at long-term solutions on funding. But there are things we can do in the short term, particularly integrating local authority social care with NHS healthcare, that will help people and prevent harm right now. So I'd like to see the government much more assertive and acting on social care in the short term. I think the second area, as I said, is, we need to be really clear about the lines of authority here. I think it should be invested in the integrated care systems. There is confusion at the moment over, do the hospitals report to the integrated care system, or do they report to centre in NHS England? I think that confusion is not helpful. And I also think, which is a good thing, I think Wes Streeting and his team have done a good thing to say that this divide between the Department of Health and social care, by the way, it shouldn't be called social care. They do nothing about social care. On the one hand, and NHS England on the other, has not worked. It's created an arm's length body that is too bureaucratic, too much top-down targets, initiatives that are displaced from what is really happening on the ground. And what's happening on the ground is quite different in Surrey than it is in Liverpool or Hull or wherever. So I think they are getting there. They're listening, and so I think the dialogue is good. But we really need to start nailing this. And the 10-year plan is great, but we really need to get the way this system works right. Otherwise, there's a danger the 10-year plan is just going to be another report. I think the appointment of Penny Dash as chair and Jim Mackey as chief executive is very good. I think they're two very high quality people who I think do understand where we need to go. So cup half full, doing okay, but could do better.
Thank you. Got a comment saying, whilst agreeing with so much of today's talk, I was expecting to hear more about true engagement of people, not just in self-care, but in shared decision-making with their clinical teams. We need to become much less paternalistic and more collaborative with service users. I don't know if you have a comment.
I do. I think that's absolutely right. And I think and the problem is, for a 9-minute, on average, the GP appointment is 9 minutes. You can't really have that dialogue with the patient that you need in 9 minutes. So we need to take away a lot of that, those people who are going there unnecessarily, but they have needs, but deal that in social prescribing or in voluntary organizations, and give the GP real time to be able to engage with their patient, and encourage patients to be much more concerned about self-care, because we do have a mindset which is I'm ill, I'll go to the NHS, they'll fix it, and you find it's quite different in most other European countries, where there's more of an emphasis on what can you do to yourself. Stop smoking, stop drinking so much, start engineering society. But absolutely, the patient needs to have voice. Sometimes the clinicians can be a little bit, I'm the expert, do as I tell you, and we are trying to work on that. But most clinicians, all clinicians, they come into this profession because they care. So if they get a proper dialogue with the patient, then they do want to listen and they do want to make things better.
Thanks, Ian. I've got quite a few comments coming in, so I'm just going to try and rattle through a few of them. Chris said that from his experience of cancer care, the NHS seems excellent. It also seems excellent value for money and better when compared to private health insurance. Do you have a comment in relation to that?
Yeah, I think the problem is the postcode lottery. So if you're articulate and you know how to have a dialogue and you research the pathway, cancer care is amongst, and you're lucky enough to live, close to a cancer centre, the Christie or the Marsden or the Royal Surrey, actually down in our patch. And you know how to have that dialogue, then you will have a great experience amongst the best in the world. Probably the Americans a little bit better, but for elite stuff, if you're in the right place in the UK, you will get excellent care. I mean, having worked at King's College Hospital, it's just stunning. The quality of skill and science that goes on in cancer, CAR T cells. We started at King's, Ghulam Mufti, Professor Mufti, metabolic health, Professor Rubinho. I mean, these are world-class figures. So if you're in the right place, the right time in the NHS, you will get world-class care. The problem is the 20 or 30% of the population who have less voice probably present much later in the pathway and feel much less assertive. It's those people and the people who often are in the greatest need because of poor lifestyles, poverty, getting by on 25,000 quid a year, which is the average wage, probably a bit higher nowadays, is really tough. So yeah, if you're in the right place, you will get world-class care, but if you're not, you're in trouble. And we've got to address that. This is just not right in a society like ours, that we're letting the poorest in our society down so badly.
Um, Andy was asking, kind of, I suppose, thinking about that market-driven service. He says many of their healthcare systems across the world are to some extent market-driven financially. To what extent does this improve efficiency of delivery? And to what extent should we emulate aspects of these?
Yeah, I mean, it's a big political issue, clearly, and saying that you're going to not have an income or a tax-funded system free at the point of need is political suicide. However, I think we do need to have that debate. Systems like Germany, where the funding is about a third private, a third state, and a third charity, seems to work much better. There's more competition, there's alternative pathways. I think as a country, we do have to have that debate. I don't think anybody would want to go to the American system, where probably 30% of the population does not have access to healthcare. But I think a better balance between privately funded, state funded, and some charity stuff would be an awful lot better.
And how feasible, when you're talking about this kind of integrated system and bringing in some charity funding and state funding, how feasible is this without massive increases to the NHS funding?
Well, I think it's quite possible. I mean, there's a lot of inefficiency, as you can see on this, because we are putting money, because of this unmanaged system at the 2 million level, we are pumping money into the most expensive part of the system. The most expensive part of the system are paramedics, ambulances, consultants in hospitals, A&E departments, and lying in a hospital bed, which will cost £3,000 to £4,000 a week. So I think if we can make this system work better for patients, then it will be a lower cost system. Now, the problem is you do need investment in the out-of-hospital environment and changing these pathways to get there. And that is a problem at the moment. We are trying to make this shift to more out-of-hospital community-based care, but without any extra money. I mean, clearly, if you're in the private sector, you would raise capital, you'd invest in the out-of-hospital environment, you'd have an ROI. After 5 years, you'd begin to get the return on investment. The problem is, as I said earlier, we don't have the capital or the RevEx to be able to make that shift. So we are trying to to make that shift when we're right in the middle of a fast flowing stream in flood. And it's not easy, but we have got to try because this is just getting worse, worse and worse.
Um, just thinking about when you were talking about some of the efficiencies, there's a question around the fact that evidence-based medicine has been around for a while, but were you kind of implying earlier that evidence-based management has been missing? So, and if so, to what extent will IT and AI assist in management? Underused resources.
That person stole my line. Great. I love saying, we've got evidence-based medicine, we don't have evidence-based management. So a gold star to whoever said that one. I think that's absolutely right. As I say, to be fair to the managers and the clinician managers, it is such a frenetic system. It is so difficult for them to stop, do some analysis, have a strategic perspective because they're pulled all over the place. And the second problem is that there's this pejorative view of management that somehow management is administration and bureaucracy. And the first people who get cut when there's a budget problem is management. And you can't manage a complex system like this without management. What you end up with is the pinball that I've been describing. And we're probably 20–30% short of proper management. I mean, management skills is one thing, but the number of managers, especially service managers, managing, orthopedics in a hospital or managing a group of GP practices, we just don't have enough. And in the absence of that, we will have a system that is out of control. So we have got to find a way of getting more competent management, develop management. I mean, management training in the NHS is appalling. You just wouldn't find this in the private sector, that you would throw people in at the age of 20 and then hardly give them any management development until they retire at 65. So we've really got to start supporting managers and more clinician managers, because it is an advantage to have a manager who has a clinical background, a nurse or a doctor, because they clearly have more sway with their colleagues. And I'd say again, I hugely admire our clinical and care workforce. They are fantastic. And as I said before, some of the best in the world in clinician science. My brother's a professor of obstetrics and gynecology. So, I have a lot of insight into that clinician scientist. He was chief executive at Imperial College. These people are world class, but we're not giving them the chance to deliver that world class expertise and the care that they feel in a system that's not supporting them adequately.
Excellent. And you were mentioning at the start of that there's kind of a shortage in management staffing as it is, but somebody else has asked about staffing in general, and says that we're told that the NHS is short of tens of thousands of nurses and thousands of doctors and specialists, yet there doesn't seem to be a coordinated long-term strategy for recruitment and training. Do you have a comment in relation to that?
Yeah, I think that's absolutely right. I mean, there is a workforce plan that the Conservative Party did, but it was uncosted. I mean, again, I think that's the thing the Labour government has got to get a hold of and have a proper plan. And the second part of that is to integrate health and social care workforce. 60% of the social care workforce, which is nearly 1.5 million. It's nearly as big as the NHS workforce, which people often don't realise. People working in domiciliary care, home-based care, and care homes. 60% are on minimum wage. So retention, turnover, recruitment is incredibly difficult. So if we can begin to merge the health and social care workforces, give the social care workforce career paths. So if somebody comes in as a carer on minimum wage, but give them a path to become a nurse or a paramedic or even a doctor, we would make the whole system better. Because as I said before, people come in, the 3 million people who work in health and social care do this because they care. Working in a care home on minimum wage, you will get more money at Tesco down the road. People are doing this because they care, and we have got to look after them better, develop them, give them the skills they want. As I say, they want to look after the patient who is in front of them. They really care. So give it another couple of minutes and then I'll
Okay, yeah, I'm just
Polly,
having
I don't know if there's more demand for.
there's lots and lots and lots of questions, so I'm just having a quick look through. Uh, Somebody again was asking about the possibility of, I mean, AI is coming up as a bit of a
Yeah,
theme,
yeah,
incorporating AI and app healthcare services.
yeah. Absolutely. I mean, it's obvious it's going to be a huge advantage at every level. AI in terms of reading images, um, AI in terms of of spotting trends in genomics, and ambient AI. Again, the problem is management. Everybody knows whether whatever sector you're in, throwing IT at a problem, if you do not have the people and the processes in place, will be a huge waste of money and a huge disappointment. And I'm afraid that is where we are at the moment. We only put an electronic patient record into two of our hospitals in Surrey last year or the year before. So we're coming from a long way back, and we do have to get the management and the processes right, because otherwise, as I say, we will waste an awful lot of money on IT and AI, and unfortunately, not deliver the care and benefits that patients and citizens and taxpayers really deserve. Let's give it one more, Polly, and then I'll move on to
Okay, I'll just pick something. I think you talked a lot before about, I think this one could kind of resonate with some of your earlier themes. And Caitlin asked, can we incentivize people to take more personal responsibility with regards to prevention? Or are the problems related to smoking, obesity, poor bone density in the elderly, etc., too structural for individuals to resolve?
Yeah, I think we can. I mean, I think the national government has failed on this. We have the highest rates of childhood obesity in Europe, and that's disgusting, really. And it's because the food companies and the lobbyists and libertarians, do not, block progress on this. This isn't an issue of free choice. This is setting children up for failure in life and ill health, and we just can't have that. So I think we do need to work much harder on public health generally at a national level, and as I say, at a local level, so that we do have pathways, that help families who are having trouble affording the food or buying bad food and that is harming their children, and get much more involved in that sort of daily, daily rhythm of life for people.
Thank thank you, Ian. That was just, I think you just did such an outstanding job of giving me so much information and managing to cross the two and integrate them together. It was really wonderful. So I'd just like to say thank you very much. I was also going to invite Chris, who's the president of the All-Arian Committee, to just close with a few words, if that's okay.
Okay, thanks, Polly. Well, again, I'd just like to echo what you've said. The expertise of All-Arians in a wide range of areas never ceases to amaze me, but this has been an absolutely outstanding talk. So thank you very much, Ian. And I just want to echo your last points as someone who has a lot of unfortunate, unplanned interaction with the NHS, shall we say. The people who work there are outstanding. Both the ones who we might think of as British nationals and those whose heritage is from elsewhere. The care, the technical ability is outstanding, and we need to nurture those people and recognise what they do. So just finally, I'd add my thanks to Polly for hosting today and for organising this event, and not least to Emily Bruce from the Development Office, who always is a tower of strength and support in getting these things organised on behalf of the association. The cooperation we have from the Development Office is excellent. I just want to finally mention a couple of things that we have coming up. It's a little way off yet, both of them, but the 21st of November, we have our London lunch again at the Army and Navy Club. We had record attendance last year with 69 people. The room takes 75. So if you want to be there, keep an eye open for bookings opening, and get your application, your tickets bought early. And I'm in discussions with Wardour Street again about a London dinner next year on the 3rd of February. That's yet to be confirmed. So that is about it from me. Thank you again on on behalf of myself and the Hall, for all the support that all Areans give to the Hall and to each other. And with that, I think we can close, Polly.
Thank you, Chris. Yep, thank you very much for attending. And Emily has recorded the session. I know a few people were asking about the recording, and I think she will endeavour to get that out as well. So thanks once again for Ian and for all of you who came along today, and that marks the end of the webinar. Thank you.